I like to address the reasons and the treatment of recurrent implantation failure today in 20-25 minutes. So it's one of the most debatable topics in reproductive endocrinology. And let's start with the definition of recurrent implantation failure. In fact, there remains a controversial topic. No consensus on its definition, diagnostic and therapeutic measures, unfortunately. But mainly, this is the general definition, general accepted definition. It's at least 3 IVF attempts or 4 embryos transferred in women less than 40 years of age. I'd like to emphasize that less than 40 years. So if a woman is over 40, 43, 42, 43, and who had 2, 3, 4 IVF attempts over 40, so they cannot be classified as having RIF because of the age factor. Because as the woman gets older, the quality of eggs gets much lower. It's a basic and very important factor in terms of getting pregnant. Approximately 10% of women undergoing IVF treatment suffer from recurrent implantation failure. 10%. So let's look at this slide. If you take a look at it, after almost 6 attempts, almost only the 10% of them get classified in RIF. And as I mentioned to you, this is the age and fertility potential. As the age gets older, the fertility rate, fertility potential decreases significantly, drops down almost zero after at the age of 45. And the rate of miscarriage, rate of spontaneous abortions gets higher, significantly higher after the age of 40. Almost 50% of pregnancies occurred in women over 40 ends up being miscarriage. So it's very important due to oocyte factor, egg factor, because the chromosomes located inside the nucleus of egg gets older and becomes much more vulnerable after fertilization, yielding a very poor pregnancy rate. This is the IVF success and the age. Again, if you look at it, the success rate throughout the world is about 40-45%. This is a live birth rate at the age less than 35. 35, 37, goes down to 40%. And around 43, it's less than 10%. So please pay attention to this significant drop in pregnancy and live birth rate due to aging. And there are 2 obstacles in the process of IVF. The first one, fertilization failure. The second one is the implantation failure. Fertilization failure means that after the injection of sperm into oocyte, or in conventional IVF, when you put the sperm by the egg, sperm is supposed to get into egg. If they don't get into egg, or after intracytoplasmic sperm injection, if fertilization does not happen, it's considered fertilization failure. However, implantation failures means not achieving pregnancy upon embryo transfer. The first group, I like to again address the pregnancy in women with recurrent implantation failure. A cumulative live birth rate of almost 50%, with a median time to pregnancy of 9 months after diagnosis among women with RIF. So there's a reasonable live birth rate over time where couples continue to try. So please, the first rule, the rule of thumb, do not quit trying to get pregnant if you are under 40 and if you are classified as having RIF. So do not quit trying to get pregnant. Almost 50% of women get pregnant in 9 months. Causes of our recurrent implantation failure. Let's start with poor oocyte quality. So this is the factor related to women. This factor is related to men. Poor sperm quality. There is a test named sperm DNA fragmentation analysis index. So this can be performed in men with normal sperm count or low sperm count, but not able to fertilize the egg. So this test can be performed to elaborate the problem of RIF. So poor sperm quality is a main factor, is a serious factor. The other one, this is related to laboratory of the IVF unit. Suboptimal culture conditions. It's a very drastic, plays a role in the success of IVF attempts. So suboptimal culture conditions is very important. Suboptimal embryo quality. Whatever we do, we sometimes end up having low quality embryos. Unfortunately, we wind up having low quality embryos. So this is also a very important factor. Suboptimal embryo transfer. This is a very important step in the process of IVF. It should be done very carefully, and the experience of the physician plays an important role in the optimal embryo transfer procedure. So it's an important factor again. And again, this disturbed endometrial receptivity. This is also related to women. Endometrium is supposed to be ready for the implantation of the embryo in terms of biochemical maturity and the histological maturity. So when the embryo arrives at the uterine cavity, it attached to endometrium, and endometrium should be receptive. There's so-called window of implantation when the embryo arrives at the uterine cavity. So endometrium should be ready, waiting for the embryo to implant. These are the main issues in terms of having a normal, healthy pregnancy. So this is the summary of the factors affecting, playing roles in the RIF. Maternal factors, some interventions. I'd like to get into some of them lately, and other factors. Let's start with maternal factors. I mentioned about sperm factor and the test, DNA sperm DNA fragmentation test. And in terms of maternal factors, anatomical problem is the most important part. The other one, thrombophilia, and genetical problems, chromosomal problems, immunologic problems, infections, and some molecules in the endometrial receptivity are also accused of being important in the implantation implantation process. But let's start with anatomical factors. Before that, I'd like to give some basics which are accepted worldwide. These are obesity and or significant underweight. These two factors are important in the etiology of recurrent implantation failure. So please try to be in normal body mass index. Trying to having normal body mass index between 20 to 30 gives you an advantage of getting pregnant. It's very important to have very much fat or low fat in the process of pregnancy. Smoking is another factor, very important. So please stop smoking. especially heavy smoking or alcohol drinking, are very important factors. These are basics in terms of getting a healthy pregnancy. Another two, diabetes. If you have diabetes, the glucose level, your endocrinologic changes should be regulated. Yeah, the glucose metabolism should be regulated by either use of insulin or some oral medication. So diabetes is an important factor. The other one is thyroid dysfunction. You should have normal thyroid hormone levels prior to attempting to get pregnant. So you have normal glucose function, glucose levels, and normal thyroid hormone levels to get a healthy pregnancy. These are basic rules. Chromosomal problems also plays an important role. When you consult your physician, he will tell you the basic advice about the chromosomal structure. So when we have couples having RIF, one of the first tests we order is the chromosome karyotype testing. It gives us information on the chromosome numbers as well as some structural abnormalities. So chromosomes are very important to get a healthy baby. The other one is uterine malformations, anatomical factors. Uterine malformations can be classified uterine septum, Asherman syndrome. This is adhesions. I'll show you some photographs of it. Endometrial or cervical polyps, submucous fibroid. These are main problems, anatomical problems. And hydrosalpinx. This is the fluid accumulation in the tube, which might impair the chance of implantation. The last but not the least, endometriosis and or adenomyosis is a very important factor to get a healthy baby. So we like to assess the cavity before an IVF or in all couples having RIF. Cavity assessment can be done by ultrasound, vaginal ultrasound, 2D or 3D, sonohysterography. We do inject some fluid inside the cavity and check out try to find out any abnormality in the uterine cavity. The other one, hysterosalpingography, it's historically most performed test to evaluate the uterine cavity. And the last one, hysteroscopy. All these tests should be done to assess the normality of the cavity before making any further attempt. I'll show you some photographs of abnormalities. This is the uterine septum. In case of implantation of the embryo on this area, the pregnancy will fail because there is no place on this area to feed the embryo. That's the reason if you find out that there is a problem, there is a septum inside the cavity, it should be removed, it should be cut, and the cavity should be corrected, should be fixed. It's very important. The other one, as I mentioned, is a hydrosalpinx. The fluid inside this tube might leak into the uterine cavity and disturb the endometrial receptivity, causing implantation failure. So it should be removed. Hydrosalpinx should be removed before any IVF attempt. So this is the photograph of hydrosalpinx by vaginal sonograms, kind of disturbed tube, swollen tube, filled with fluid inside. This fluid accumulated inside the tube is harmful on the endometrial receptivity. This is adenomyosis. Adenomyosis is the location of endometrial remnants, endometrial tissue inside the uterine muscle. This also impairs the chance of pregnancy. It's important. This is so-called Asherman syndrome. Asherman syndrome is the adhesions, severe adhesions inside the cavity. This also lowers the chance of pregnancy. It should be removed. All these adhesions should be fixed, should be cut prior to further IVF attempts. This is important. So, therefore, in couples with RAF, should be evaluated, should be analyzed for the presence of a uterine or tubal anatomical abnormality in order to start or before starting any further attempt. The second one, this is a little bit a debatable issue. I tried to get the recent data published by the Canadian Health Organization, and I like to base on the data published recently. So I'll give you some evidence-based data as far as some debatable topics. So thrombophilia is a debatable topic in the etiology of recurrent implantation failure, because there are some studies which show the efficacy of screening all these tests, but it's not accepted worldwide. But many centers are getting these tests in women having recurrent implantation failure. I like to mention briefly factor V Leiden mutation, protein S, protein C deficiency, and all other factors. These are so-called congenital thrombophilia. Having this problem might cause thrombosis, some clotting in the product of pregnancy, and prevents the embryo growing. So these should be screened in women with RAF. The other one, acquired thrombophilia, antiphospholipid antibodies, antiphospholipid antibody syndrome. This is so-called antiphospholipid antibody syndrome. And there are some other tests to evaluate this problem. This is acquired thrombophilia. Again, this is also debatable, but many papers, many studies on the importance of having this problem in recurrent implantation failure. So this is the risk factors of congenital thrombophilia, factor V Leiden mutation, and others. Once you have one of these problems, the likelihood of having miscarriage gets higher. Again, this is antiphospholipid antibody syndrome. These tests should be screened to rule out antiphospholipid antibody syndrome, because we know that this plays a role in the etiology of recurrent miscarriages or recurrent implantation failures. So I mentioned the reasons, etiology of RAF, but now let's talk about the treatment of it. As I told you in the first slide, neither definition nor the treatment is clearly identified or accepted worldwide. So there are many debates, obstacles in the treatment of this problem. But there are some tests recommended to perform in these couples to increase pregnancy rate. One of them, PGT, pre-implantation genetic tests for an aneuploidy. PGT, there are insufficient data to recommend for or against PGT for RAF. We also recommend we recommend this test in some women having RAF, but still, yet there is no solid data on the benefit of this test. Endometrial receptivity assay to assess window of implantation, so-called ERA test. It's also debatable because it's done in frozen, in artificially prepared cycle. So it doesn't mean that all women produce same type of biochemicals in each cycle. Therefore, it's debatable, even though many centers recommend this test. This is so-called ERA test, endometrial receptivity assay. Freeze-all strategy is very popular these days because of high estradiol level, physiologically high levels or supraphysiologic levels of hormones obtained in the ovarian stimulation cycles. We sometimes opt to freeze all the embryos obtained in fresh cycles after ovulation induction, and freeze them all and transfer it in the next cycle after thawing. This is freeze-all strategy. The main goal is to avoid the harmful effect of supraphysiological hormone levels in the fresh cycle. It works in some cases, but it's also we also still more studies, more research on the benefit of freeze-all strategy in women with RIF. Uterine microbiome, it's one of the new topics, new topic of studies to get the idea of uterine microbiome, because there are many types of microorganisms lie or live in the uterus. So we are trying to clarify the role of these different microorganisms and try to get an optimum, more physiologic ratio of these microorganisms in uterine environment, in the endometrial environment. But there's still need of further research to make comments on the importance of different microbiomes, but it is an open topic for the future studies. The other one, endometrial scratch. Almost 5-6 years ago, there was a paper recommending or suggesting the use of scratch or injury, endometrial injury, to enhance implantation rate in women having RIF. The main goal is to make an injury in the endometrium, stimulating some stem cells or some chemicals to improve pregnancy rate. There was a good idea, or there was a new idea to increase endometrial receptivity. But studies after the first one didn't exhibit the same beneficial effect of scratching, but therefore there's still debate on the efficacy of this method. The other one is the use of anticoagulants, the clexane or aspirin in these women. So it's also debatable because it's accepted in women having antiphospholipid antibody syndrome, but use of aspirin and or low dose heparin, low molecular weight heparin in all women is very debatable. It's not accepted, even though it's used very commonly. But there's again need of further research. We do try these medications in women having antiphospholipid antibody syndrome, evidenced by the presence of the tests I mentioned about. The other one is the intralipid solution. This is used to stimulate some immunologic factors as well as some chemicals in the uterine environment in the hope of increasing implantation rate. Even though there are few studies on the benefit of intralipid infusion of intralipid solutions, it's at least harmless method of increasing pregnancy rate. There are some other methods to be recommended in the treatment of RIF, such as natural killer cells, granulocyte colony stimulating factors. There are some others, but I like to emphasize that none of this has been accepted the best or gold standard treatment in patients with RAF. So there are many research, there are many studies on each of these attempts, each of these methods, but still we need some more data to make certain conclusions in the efficacy of these treatments, even though we have been trying some of these methods to improve pregnancy rate, because the patients having these problems are desperately sometimes seeking help to get pregnant. So we utilize some of these treatments methods to increase pregnancy rate. So in summary, please do not quit trying to get pregnant. As I mentioned, in a year, almost 50% of couples get pregnant. Try to least harmful and least expensive methods, since there is none accepted worldwide. PGTA might be tried to evaluate the chromosomal patterns of the embryos. Intrathecal infusion, which is least harmful and one of the cheapest modalities to treat this problem. And endometrial scratch, low-dose heparin and aspirin are also experimental methods to improve pregnancy rate. And of course, try to be on a regular diet and do exercise. These are two main methods to improve pregnancy rate. I wish you good luck. Looking forward to seeing you in Turkey.